I have performed flank and midline spays, and often the question is which is better. After performing over 50,000 spays, I believe this to be the best answer. Post-operative problems are less with flank approach, with wound breakdown being the largest problem with midline. Regards performing the surgery, midline is best. There are so many disasters that can occur with flank and when problems arise. The flank incision has to be closed and then entered midline to rectify any problems. This would be my incision point using the triangle technique. Height-wise, this looks okay, about halfway down the cat. However it looks to caudal, this would be in an area where the external muscle is paper thin, and possibly the internal muscle would be inclined to tear. Exteriorization would be harder for the ovaries, but very easy for the bifurcation. We need to use just anatomical points to get the incision site best, not guessing where the third point should fall. Using the cranial part of the pelvis just in front of this point, the iliac crest, tends to be best for young cats, but for older cats, where the bifurcation is more cranial, a finger in front is best. So this marker for young cats. This marker for older cats. To decide on the depth, the uterus is about a finger below the vertebrae. So draw a line of this position and this the highest point you can go. So this green diagonal line is where I would make my incision. The reason it's diagonal, the cranial part would be closer to the ovaries and the caudal part the bifurcation. Note that the incision site is roughly halfway down the cat. Once you have marked your incision site, do not move the skin. You are usually best marking this when the patient is draped. New graduate errors. Over 70% of new graduates will enter the cat in the wrong location with their first spay. 30% will enter the cat in a dangerous location. Flank spays only go well if your incision point is correct. When the incision is to caudal, the external muscle is like paper, and the internal muscle is likely to rip and tear. Scary new graduate error, incision to high and entering the retroperitoneum, and thus damaging ureters. Unfortunately, there has been reported deaths from this scariest error. 15-year qualified colleague removed a kidney and ureter, believing it to be ovary and uterine horn. The cat survived after a specialist surgeon took over. It's always worth checking where the femoral head is located. New graduates have confused the femoral head for the cranial part of the pelvis, thus making their incision into the musculature of the leg. Femoral head, most cranial part of the pelvis. This is an older cat, so we mark a finger in front. Now a finger below the vertebrae, so we avoid a ureter disaster. Looking at the video now, I would say I went a little too high and too close to the ureter retroperitoneum area. Most new graduates will move the skin while they make their incision, so the entry point differs to what they have marked. This could then put them in a dangerous location despite correctly marking the incision. Gently press down with the blade and be careful not to cut too deep. If you want to stretch the skin, make sure not to move the position. Now remember, we only need a small incision as we find the uterus with forceps, roughly about a centimeter if you intend to do larger incisions. Then you will be better of performing the spay midline for the cat's sake. We want to remove a fat window, roughly 30% will remove not enough fat, and later get confused between the skin fat layer and the peritoneum fat. About 20% will remove too much fat and accidentally cut out part of the external muscle, thinking they were still just removing the subcu fat and looking for the internal muscle. They cut massive holes in the external and internal muscle, started cutting out abdominal fat, actually chopped out the ovary and part of the uterus, chopped through mesenteric vessels, and experienced surgeons stopped the vet, and managed to repair all this damage. The cat luckily made a full recovery. To prevent any disaster like this, snip away a small amount of fat, and then blunt dissect the fat down to the muscle so as you are cutting away the window, you can see the external muscle and not accidentally damage it. With our entry, we need all the openings lined up above each other. So now use 2 pairs of forceps, grab the muscle in the center, raising it. Then use the other pair to grab the muscle to the side. So you are making the snip where the first forceps were, which should be central. Make sure the scissors are at 90 degrees to the muscle. You want a clean, not dog-eared snip. Now pull the internal muscle through the external muscle window, and then repeat the snip. This layer is thicker as it is made up of 2 muscle layers fused together, so you may need to snip a few times. Keep the muscle tented up to eliminate any risk of damage to the abdominal contents. The majority of new graduates on their first spay don't manage to open the peritoneum with a muscle snip. You will see the peritoneum as a clear film. If you can't see a window in this clear film, then tear the peritoneum gently open with forceps. If my snip fails to enter the peritoneum, I pick up some abdominal fat and tear open the peritoneum so I can't damage any vessels or organs. Scary new grad error. External muscle was accidentally cut away with the fat, thinking the internal muscle was the external. Colon was then mistaken for the interior muscle and was cut with scissors. Luckily was repaired and miraculously healed without complications. Similarly, the bladder was mistaken for the internal muscle and was cut open. An abdominal incision was made and the bladder repaired. You can see the color of the fat changes from yellowy to white once the peritoneum is torn. This solid-looking fat is the lumbar fat pad. The uterus just sits below it and has an attachment to the fat pad. As you can see, each entry is below the previous, so they are lined up nicely. You can now see why we only need a small incision, and to be honest, a larger incision would make everything more difficult, as more abdominal contents would be exposed, hiding the uterus. To find a uterus, it's below and attached to the lumbar fat pad. It's above the intestine. It's above the mesenteric fat. Ideally, find the lumbar fat pad and look below. You can roll up the lumbar fat pad to find the attachments. Hold the internal muscle while searching and use wide traumatic forceps to pick up abdominal contents. See how once you have the lumbar fat pad, you can just roll it upwards to get the uterus. I am just exposing the mesenteric fat so you can see the difference between the two. The lumbar fat pad is more solid, the mesenteric fat is a little more stringy. I don't expose the intestine as it could result in minor damage. Common scary errors: the small intestine was extensively pulled out. With the vet thinking it was the uterus, the intestine became stuck in the muscle opening and started to become ischemic. A midline incision had to be made rapidly to pull the intestine back into the cavity. The cat recovered. With both flank and midline incisions, I never break suspensory ligaments due to bleeding from the ovarian attachment. Make sure there is good clearance of the ovary. I use Alice tissue forceps to stretch the uterus out. Always rotate the clamp, as this prevents ligatures getting caught in the skin or muscle. One large difference between a bitch and cat spay is the ovarian artery pressure is less, so I use simple surgeon ligations. I would recommend 2 to start with and then drop down to 1 as your confidence grows. This is how I rotate the ovarian pedicle clamp by placing an instrument through the handle. Make sure your ligatures are nice and tight. I'm using Metric 30 USP coated multifilament. If you have room, raise the ovarian clamp and then place the second ligature. Again, rotate the ovarian pedicle clamp. We can now remove the first ovary. Try to avoid placing the clamp on the ovary, as there are theories if you clamp the ovary, ovarian tissue may seed out, resulting in ectopics. Ovarian remnant syndrome, ORS. To remove the ovary, use a blade flush to the clamp. When we release the clamp, theoretically we should hold onto the pedicle. From my experience, this damages the pedicle, resulting in ligature slippage. So I visually check the ligatures for tightness and just release the clamp. Tear the broad ligament so you can fully exteriorize the uterine horn. The more exteriorized it is, the easier it is to find the other horn. New graduate errors: typically the ovarian clamp is not rotated before ligation. This results in ligature attachment to the skin, muscle, or tissue on the left side. So, when the pedicle is released, the ligature falls off. About 10% lose an ovarian pedicle in their first spays. This tends to result in some bleeding, but quite often this quickly stops. In a bitch spay, this would be a complete disaster. In years past, some vets used to twist and pull on the ovarian pedicle without ligation. This should help you to understand where you need to look to find the second uterine horn. New graduates often don't look cranially but caudal. And with this method, you will probably see nothing or just the first uterine horn. I use a pair of curved traumatic forceps to find the other horn, parting the tissue away. until I can visualize the horn and then grasp it with the forceps. If this is something you continuously struggle with, then it's best to make your entry point a little more caudal. Try and get a good clearance from the ovary, so you will be able to raise the forceps for the second ligature. Check there is no other tissue in the forceps. The clamp is then raised to make room for the second ligature. Always rotate the clamp before tying the ligature. New grad errors. About 10% will accidentally pull up as they tie the ligature. Some so much so, they snap off the ovarian pedicle. This can also happen when they ligate the uterus. Remember not to pull up on the tissue you are ligating. Remember to break down the broad ligament on this side. Very rarely there are vessels present, and if so, I ligate them. Common new graduate errors using forceps to make a crush bed. In a fragile uterus, this can result in hemorrhaging. Placing very tight millers with PGA or PDS. And this can cut through, cheese wiring the uterus. When removing the uterus, possibly half of vets worldwide will remove only the ovaries, leaving the entire uterus. So don't stress and pull hard on the uterus as you risk causing damage, rather than making a larger incision to remove the uterus completely. The majority now feel it's better to keep the incision site small and just remove as much uterus as you can. The main necessity is that the ovaries have been removed completely. Because of the cheese wire risk, I only use surgeons on a cat's uterus, never millers. Unless it is a pregnant uterus. I sometimes place the first ligature some distance away. So, if it does cut through, I have space to place another. Occasionally, I use the dreaded catgut, as it is less likely to cut through. ND knot security is excellent. We can just get in front of the bifurcation. The uterus seems quite healthy. So I place the first surgeons quite low down, but use catgut to be on the safe side. The next surgeons is with coated and dyed multifilament to metric 3OUSP. Before you start your closure, check your layers: fat, external muscle, and internal muscle. Start with the internal. I close with cruciates and use the tail to raise the muscle, making it easier to pass the needle. Take nice bites of the muscle, as thin bites are more likely to tear. See how much easier it is using the tails to raise the muscle. The knot doesn't want to be too tight to prevent post-op swelling and discomfort. I have left the long tail with needle attached and just snipped the tail. Carrying on with the suture pattern into the external helps to reduce the gap between the muscle layers. We start the external muscle by passing the needle deep superficial. The external muscle is difficult to close neatly and often looks dog-eared. Because we removed the fat window at the start, we have good visibility of the layers. I usually close the external with a continus or cruciates. Now the external muscle is tied off and we then close the fat. You will have to use the forceps to grab the fat, as quite often it underruns the skin quite some distance. The fat easily can turn into a hematoma, and in the past new grads have thought it was a third muscle layer. As you can see in the video, the fat looks more similar to muscle. The fat closure was finished with a surgeon's knot. The suture material is too large to follow on with intradermals. So the knot was formed in an area which should be easy to cover with the skin closure. Classical new graduate errors. Many new graduates would close the external muscle layer, thinking it to be the internal, or believing they had closed both layers together. Always find the first muscle layer and then you know. The one below has to be the internal. New grads who had made their incision to caudal struggled to close the internal due to muscle ripping, and the external was paper thin, making wound breakdown a real concern. Snipping the tails so they are as short as possible. We are using Temetric USP30 coated multifilament. I always start the intradermals with a surgeon's knot, as this forms a much better anchor for the intradermals. Finish with a surgeon's knot or an Aberdeen, risks v benefits. Surgeons will not break down but will be slightly harder to bury. Aberdeens quite often unravel in cat spays but are easier to bury. You often see them 10 days later with the suture material dangling out of the wound. To minimize this, pass through twice on finishing and try and leave a longer tail. By coming out of the skin quite some distance away. Raise the skin over the needle to help perform this. Burial is essential, otherwise the knot sits between the skin, preventing edge-to-edge healing. Ideally leave a small opening when closing. So you can pass the needle through this and burial will be easy. Pass the needle through the wound close to the knot. Lift the skin over the needle so the exit from the skin is quite some distance. As a general guide, if the needle passes easily, burial should be easy. If burial seems impossible, pull the suture back out and change to a larger needle. Roughly only about 20% of new grads manage successful burial on their first spays, resulting in partial wound breakdown 1 to 2 weeks later. Only veterinary surgeons can receive a degree in surgery and have never performed surgery